Well, it's changed quite a bit recently. We used to think about either a radical prostatectomy or radiation therapy for men with newly diagnosed prostate cancer, especially intermediate risk or high risk. Now, when we think about patients who are particularly at high risk, we know that many of them, if they start with surgery, they're going to go on to radiation therapy, usually with hormonal therapy. And when we look at single institution series or retrospective reviews of how patients respond to either surgery or radiation, it's interesting because many patients do better, it appears, when they start with surgery. And that may not be that surgery is superior to radiation. It may simply be that patients who start with surgery are more likely to get multimodal treatment. They're more likely to get surgery and then radiation therapy and hormonal therapy if they have progression or adverse pathology. So we really don't think about giving radiation therapy and hormonal therapy after surgery as failure. We think about it now more like other solid malignancies. For many years, for breast cancer patients, we've given surgery plus radiation therapy as a routine part of care. And I think for higher risk prostate cancer, I think about it similarly now. I tell men that we're going to start with surgery if they choose surgery rather than a primary radiation therapy technique. And if they have adverse pathology or a PSA recurrence, we'll use radiation therapy and hormonal therapy quite safely. So they're sort of prepared for that concept prior to treatment, particularly for high-risk disease. And then you may have seen today, one of the abstracts that was presented was a long-term trial of the value of hormonal therapy in the interval of hormonal therapy when men get radiation therapy. And for many years we were using hormonal therapy at 2 or 3 years based on some old trials. And when men are undergoing hormonal therapy, it has some side effects. So they have hot flashes, and it can have some negative characteristics in terms of fatigue, and they gain weight, etc. So men like to be on it shorter. And the trial that was shown today compared 6 months of hormonal therapy to 18 months and showed that 18 months was superior for clinically localized high-risk prostate cancer. These are men getting radiation therapy, routinely getting hormonal therapy. So now it really kind of confirmed our thinking that it looks like for men with intermediate risk disease, 6 months of androgen deprivation therapy with radiation is adequate. For men with high-risk disease, 18 months is adequate. And it's clearly superior to 6 months for high-risk disease. So that's really nice to have that strong information from an important clinical trial. That was just presented today.